Good afternoon and welcome to this month's Northern Virginia Health Policy Forum. I'm Jim Scott, President and CEO of Applied Policy, a health policy and reimbursement consulting firm based in Alexandria, Virginia. My colleagues and I host these forums to promote an exchange of ideas and challenges facing 21st century American healthcare today. Today's forum is about Medicare Advantage. With the increasing rate of seniors enrolling in the Medicare Advantage program, this program is more important than ever. Medicare Advantage plans have been an option since the 1970s, but it was really the Medicare Modernization Act of 2003 that substantially changed the program and propelled its growth to what we see today. Along with that growth come some concerns regarding claims denials, out-of-pocket copay costs, prior authorization for needed medical benefits, and limited networks of doctors and physicians. Today, to delve into some of those issues, we have Meredith Freed, Senior Policy Manager at KFF's Program on Medicare Policy, and Gregory Berger, Principal Policy Advisor for Government Relations at Kaiser Permanente. I should note that KFF and Kaiser Permanente are not affiliated. Thanks for joining us, and let me turn it over to the panelists to introduce themselves. Meredith, can you tell us a little bit about KFF and what led to your role there?
Yeah, hi, thanks, Jim. First, I just want to start by thanking Applied Policy for having me here today. Again, my name is Meredith Freed, and I'm a Senior Policy Manager with KFF's Program on Medicare Policy. KFF is an independent source for health policy research, polling, and journalism. Our mission is to serve as a nonpartisan source of information for policymakers, the media, the health policy community, and the public. And as Jim mentioned, we are not affiliated with Kaiser Permanente. We are actually no longer called Kaiser Family Foundation. We are just simply KFF. And I work on a variety of topics related to Medicare policy, but one area we've been tracking closely is the growth of Medicare Advantage, which has really taken off, particularly in the last decade or so. And I look forward to discussing elements of the program with the panel today.
Thanks, Meredith. Greg, can you tell us a little bit about Kaiser Permanente's healthcare delivery model that includes providers and as well as Medicare Advantage plans, as well as your role there?
Sure thing. Thank you very much, Jim, and also thank you to Applied Policy for having me here today. Kaiser Permanente is the largest private integrated delivery system in the United States. We have about over 12 million members across all of our lines of business, and that includes nearly 2 million Medicare Advantage enrollees. And Kaiser Permanente represents primarily three entities: the Kaiser Foundation Health Plan and Kaiser Foundation Hospitals, which are both nonprofit organizations, and then the self-governed Permanente medical groups that exclusively contract with Kaiser Foundation Health Plan. So we have a large integrated financing and care delivery system that marries the coverage, health insurance coverage for our members, and care delivery through our hospital and physician partners. I've been here for about a year and a half. I spent 15 years in Washington, D.C., doing a mixture of consulting and also working for America's health insurance plans on Medicare Advantage and Part D issues. And here at Kaiser Permanente in the Government Relations Department, I support our Medicare Advantage and Part D policy development and work on a number of related issues, including quality and dual eligibles.
Great, thanks, Greg. So let's start with an overview of the Medicare Advantage program. Meredith, can you give us the big picture of what Medicare Advantage is and how it's different from the original Medicare fee-for-service program?
Sure. As you know, there's the traditional Medicare program, which offers Part A and B benefits, but people can also receive their Medicare Part A and B benefits through a Medicare Advantage plan, which is offered by private insurers, and those are typically PPOs and HMOs. Medicare Advantage plans are also able to offer extra benefits that aren't available in traditional Medicare plans. These include things like dental, vision, hearing, and many more additional benefits. Most Medicare Advantage plans also typically include Part D prescription drug coverage. If you're in traditional Medicare, you need to buy a separate Part D standalone drug plan. Medicare Advantage plans also have an out-of-pocket limit, which traditional Medicare generally does not. However, in traditional Medicare, you can also purchase a Medigap policy, which covers some of the out-of-pocket costs associated with Part A and B benefits, which in some ways sort of serves as an out-of-pocket limit. Also, just traditional Medicare, you can see any provider that accepts Medicare. While as Medicare Advantage plans, you typically have a network of providers. And if you go out of network, you either have to pay more or don't have any coverage at all for those providers. And lastly, Medicare Advantage plans can employ utilization management tools, such as prior authorization, which is very limited in traditional Medicare plans.
Greg, anything to add about the differences between the traditional Medicare fee-for-service program and Medicare Advantage?
One other element that I would add is that Medicare Advantage plans have greater flexibility in how they contract with providers than under the Medicare fee-for-service program. So most providers in fee-for-service are paid fee-for-service, with the exception of a range of alternative payment models like accountable care organizations and some of the demos that are run out of the Innovation Center. Medicare Advantage plans, conversely, are allowed to enter into private contracts with their providers and have greater flexibility to pay those providers on a sort of value-based or other kind of accountable care arrangement. And so you see a greater uptake of capitation, population-based payment models, and other kinds of risk-sharing arrangements in Medicare Advantage.
Thanks, Greg. Meredith, the KFF reports that about half of seniors are enrolled in Medicare Advantage and that you expect 60% to be enrolled by 2030. What factors are driving the growth of Medicare Advantage, and why are these plans so attractive to seniors?
Yeah, so kind of as I mentioned before, Medicare Advantage plans are able to offer some extra benefits that appeal to Medicare beneficiaries, such as dental, vision, over-the-counter benefits that are not available to people in traditional Medicare. Medicare Advantage also offers products with no or low supplemental premiums other than the Part B premium, which creates strong incentives for people to choose Medicare Advantage over traditional Medicare. In traditional Medicare, you have to purchase that standalone Part D drug plan and often a Medigap policy, both of which require extra premiums. People are also attracted to the financial protection that comes with an out-of-pocket limit. And they're also attracted to the simplicity and convenience of sort of one-stop shopping. All of their Medicare Advantage benefits are in one place, in one plan. They're A, B, typically Part D benefits, all the extra benefits, as opposed to traditional Medicare, where you have that supplemental Part D plan, potentially a Medigap plan. And the Medicare Advantage market is also attractive to insurers, which also accounts for some of this growth due to the profitability of this market. And as a result, plans have marketed these plans fairly aggressively to increase enrollment in plans. Though I will note that this year some insurers have reported facing headwinds due to higher than expected utilization, but overall, we still see this as a pretty attractive market to insurers.
Greg, since Kaiser Permanente offers Medicare Advantage plans, what makes them attractive from an insurer's perspective?
Yeah, so a lot of what drives our offering of Medicare Advantage plans is our mission as a nonprofit health plan and integrated delivery system, and giving our commercial members, who are the bulk of our membership, the ability to maintain their Kaiser Permanente coverage once they leave employer-sponsored insurance and age into the Medicare program. But I agree with Meredith's comment that the insurance industry overall is interested in and attracted to the Medicare Advantage market, both because of growing enrollment and the the aging in of the baby boomer population into Medicare in general, which has driven a lot of the growth in the last few years, and will continue into 2030, as you mentioned, and then also a relatively higher profit margin. The Medicare Advantage sort of payment system is compared to or set based on Medicare fee-for-service spending and utilization patterns. And to the extent Medicare Advantage plans can be more efficient in their benefit design and the delivery of care to their members, they have an opportunity to lower costs relative to Medicare fee-for-service, and then are able to use those savings in part for profit and then in part for the supplemental benefits and reduced cost sharing that Meredith mentioned.
Meredith, with the growth of Medicare Advantage, of course, there are also some growing pains. So can you highlight some of the challenges with Medicare Advantage due to its growth?
Yeah, so one of the challenges is that people are often aware of sort of a lot of the positives of Medicare Advantage plans that we've talked about. But they might not be aware of some of the trade-offs with choosing Medicare Advantage over traditional Medicare. So for example, they may not be aware that they are often subject to prior authorization requirements to receive services, or that they do have to choose from a network of providers, and that the doctor that they might want to see might not be in network. And particularly, if they get sick and want to see a new doctor, doctors, might not be available. So, when you see Medicare Advantage marketed, you see a lot of the positives, which there are many, but people might not be aware of some of the other elements of plans that can make it more difficult accessing care.
Thanks. And Greg, Kaiser has a relatively unique model that's able to manage some of these issues and challenges differently than if you only offered Medicare Advantage plans. So can you say a little bit about how Kaiser, about the challenges and how Kaiser manages them?
Sure. So Kaiser Permanente and the way that we organize our care provide most of that care through our affiliated Permanente medical groups. And because of the relationship the health plan and the medical groups have, as well as the population-based payment and financing that we use to cover the care for our members, we're able to align a lot of our incentives, and we're able to delegate effectively some of those functions like prior authorization to the medical groups, such that the medical groups have an incentive to and review and approve and provide care that's medically necessary and also cost efficient. So some of the processes that a more traditional health insurance carrier may employ around utilization management are not used nearly to the same degree in an integrated delivery system like ours or in other kinds of value-based payment arrangements.
Thanks.
The other thing I would just add too is that our model does look different in different parts of the country. I should have said we're in 8 states in the District of Columbia, and the majority of our membership is in California, where we have a bigger provider network. There are other areas of the country where our Permanente medical groups are a relatively smaller part of our provider network. So we do contract with outside providers as well in our network, and we do also bump up against some of the same workforce challenges that the rest of the health insurance industry is facing in terms of making sure we can provide access to a sufficient number of high quality providers for all of our members.
Thanks. And Greg, staying with you for a moment, are there sort of opportunities or positive aspects of the Medicare Advantage growth that has enabled Medicare Advantage plans to better serve beneficiaries?
Yes, I think that overall, as the Medicare population grows and Medicare Advantage becomes a larger percentage of the program, we see opportunity to change the delivery of care and the practice patterns of the system overall. So I think that some people have called that sort of the spillover effect, but as the growth rate or the growth of Medicare Advantage penetration increases in a market area, the way that physicians and other providers serve the Medicare population evolves in a way that follows the Medicare Advantage sort of managed care approach to coordinating care, integrating services, and ensuring that beneficiaries are getting their like preventive care screenings and other kinds of population-based approaches to serving the beneficiaries.
Thanks, Greg. So let's take a look at Medicare Advantage's payment system. So Meredith, can you tell us a little bit about how the Centers for Medicare and Medicaid Services pays Medicare Advantage plans differently than they would pay if the services were delivered under the original Medicare program?
Yeah. So Medicare relies on various approaches when determining payments to providers for Part A and B under traditional Medicare, but generally is using prospective payment systems for most providers. So in general, this means that Medicare sort of determines a base rate for a given unit of service that then is often adjusted for certain variables such as geographic location. And depending on where the service took place, a hospital versus outpatient, service are paid through either the Part A or Part B trust funds. Medicare Advantage doesn't have its own separate revenue sources. Medicare pays private insurers a fixed amount per enrollee, adjusted for health risk, to provide all Medicare Part A and B services. And to get a little bit technical, just to explain a little bit more how the plans are paid, the payment amount to plans is determined through an annual process in which plans submit bids for how much they estimate it will cost to provide all Medicare covered benefits for an average beneficiary. And the bids submitted by each plan are compared to a benchmark. And plans that bid below the benchmark receive a portion of the difference between the bid and the benchmark as a rebate. And I say all this because the rebates are really important because those must be used to reduce cost sharing, subsidize the standard Part B and or Part D premium, or pay for all those supplemental benefits. And importantly, insurers can also retain a portion of the rebate for administrative costs or as profit.
Thanks, Meredith. Anything else our audience should know, Greg, about how Medicare Advantage plans are paid by CMS for the care they provide?
The one additional aspect of the payment system I would add is that Medicare Advantage plans are incentivized under the Star Ratings program to achieve a certain level of quality performance on a range of measures. And Medicare Advantage plans that achieve an overall star rating of 4 or higher out of 5 are eligible for what's called a quality bonus payment. It's effectively an increase of 5% in the benchmark against which Medicare Advantage plans are bidding. And there are some counties in the country where that quality bonus payment is double or 10%.
Thanks, Greg. So Meredith, MedPAC estimates that Medicare will pay 23% more for Medicare Advantage beneficiaries than if those beneficiaries were enrolled in the Medicare fee-for-service program this year. Why are these 88 billion extra dollars going to insurers?
Yeah, so MedPAC every year regularly compares average payments to Medicare Advantage plans to what similar beneficiaries in traditional Medicare would spend, and has consistently found that Medicare Advantage payments are higher. And that estimate of $88 billion for 2024 factors in rebates, coding intensity, and favorable selection. And I'll quickly walk through each of those components. So the level of monthly rebates for 2024 is near historic highs. It's $194 a month per beneficiary, which is double the average monthly rebate than it was in 2018. And this is due in part to Medicare Advantage plans' ability to reduce their bids relative to the growth in benchmarks. In terms of how coding plays a role, as I mentioned before, payments to plans are risk adjusted based on health status. And these risk scores are largely based on diagnoses. So more diagnoses generally increase a beneficiary's risk scores, providing an incentive for diagnoses to be comprehensively coded for Medicare Advantage than in traditional Medicare. And lastly, favorable selection occurs when plans enroll healthier and lower cost enrollees than predicted by the current payment system. So in other words, Medicare Advantage benchmarks rely on traditional Medicare spending, and they may reflect higher level of costs associated with the traditional Medicare's population rather than the plan's enrollees. And so, when MedPAC's making their estimates, all of those factors together account for why plans are paid more than they would have in traditional Medicare.
Greg, what are your thoughts on MedPAC's analysis and anything else you'd like to add on the reason for the difference?
Yeah, so I would add to that that there are a couple other, when in MedPAC's analysis comparing Medicare Advantage and traditional Medicare spending, there are a couple elements of the Medicare Advantage payment system that are not being completely compared apples to apples that do account for some of that difference. One is that to be enrolled in Medicare Advantage, a beneficiary has to have both Part A and Part B. The benchmarks, which are the local fee-for-service spending used to set Medicare Advantage plan bids, are based on Medicare beneficiaries who have either Part A or Part B, and that portion of Part A enrollees has been growing over time. I think it's about 13-14% of the program overall, and then becomes a higher proportion in areas of the country where there's really high Medicare Advantage penetration. That matters because beneficiaries who only have Part A have much lower spending than Medicare beneficiaries who have both Part A and Part B. So I think there is some bias in the numbers that accounts for some of that difference. The other element of Medicare Advantage, which Meredith mentioned earlier, is that plans are required to have an out-of-pocket cap. And the Medicare fee-for-service program, or the benefit, does not have an out-of-pocket cap. You'd have to be enrolled in Medicaid or have a Medicare supplement or Medigap plan in order to have that. Some actuarial analysis by Wakely, and I think a few other firms, suggests that when you account for those two elements, that Medicare Advantage spending may actually, in comparison to fee-for-service, be the same or lower. So I do think those components of the analysis haven't been fully accounted for. But putting that aside, if you look at the raw numbers, I do think Medicare Advantage spending on average has been higher than in Medicare fee-for-service. And that is partly because Medicare Advantage covers a more generous benefit than Medicare fee-for-service. So the government is spending more, but getting more out of its spending for those beneficiaries.
Thanks, Greg. And you mentioned at the beginning about the star rating system. Can you tell us more about how the Medicare Advantage and Part D star rating systems work and how plans are measured, and what difference does that make to how plans provide care?
So the Medicare Advantage star rating system includes roughly 40, a little bit more, quality measures that cover clinical process and outcomes, patient experience and access to care, and administrative measures. Plan performance is assessed for each of those individual measures on a scale of 1 to 5. And the performance is essentially graded on a curve where CMS is looking at performance and then of plans compared to each other across those measures. They're then weighted and rolled up to an overall star rating, which CMS then makes a number of other adjustments to account for the sort of socio-demographic risk of the population of beneficiaries, and also how well they're improving their performance on the star ratings program over time, as well as how well they're performing across measures. And all those adjustments combined lead to an overall star rating. The Affordable Care Act tied the star rating of Medicare Advantage plans to the payment system through the quality bonus payment. And since the ACA was passed, we've seen Medicare Advantage plans devote a ton of resources to their performance on the star ratings measures. And so they carry a lot of weight to the plans because of the financial incentive, but also because plans are really committed to their performance and improving their performance over time.
Thanks, Greg. And under the traditional Medicare fee-for-service program, there's quality rating systems that are obviously applicable to providers, whereas the star ratings are applicable to insurers. Are there any areas of are those harmonized in any way? Do they affect each other, or are there any areas of dissonance?
They're not harmonized. The Medicare Advantage star ratings are really at the population level rather than for an individual provider. And so they're measuring different things and measuring different things for different people. And one of the challenges, I think, overall with evaluating performance in Medicare Advantage compared to traditional Medicare has been that the star ratings in Medicare Advantage can't be directly compared to any of the provider-specific like care compare measures in Medicare fee-for-service. A lot of the quality measures in Medicare Advantage are also based on EHRs or other clinical data that the traditional Medicare program doesn't have direct access to from fee-for-service providers.
Thanks, Greg. So now let's turn to talk about areas of interest to policymakers on Capitol Hill and in the administration. So Meredith, we've been hearing news reports about Medicare Advantage plan marketing tactics, including potentially misleading claims, aggressive sales tactics, onslaught of marketing materials. Can you tell us a little bit about where that's coming from and maybe some examples?
Yeah, so as you mentioned, there's been concerns in recent years about aggressive and misleading marketing of Medicare Advantage plans. And in response, CMS has published some major regulations in the last couple of years, mandating stricter oversight of third-party brokers, and also adding new requirements intended to curtail misleading marketing activities. And so, for example, one of the changes was restricting the use of the Medicare part of card or logo in a way that would be misleading. And that's important because people, would think that, some commercial that they're seeing or some documentation was, officially sponsored by the government, when in reality, they might be sponsored by a broker or by an insurer and not coming directly from the government. And that was confusing to a lot of people. They also were trying to sort of curtail plans, advertising benefits that are not available in a person's service area. So saying that they have access, to sort of a reduction in their Part B premium, which only a small number of plans offer. People call and then, find out actually that benefit's not available to me, but it's a way to get, people on the hook. They feel misled about, what's available to them. So some of those restrictions were put in place. CMS is also now generally requiring plan to submit television ads ahead of time before they're aired. And that's also intended to ensure that advertisements aren't misleading. In addition, brokers have a financial incentive to encourage Medicare Advantage enrollment because commissions are higher for Medicare Advantage plans than for Medigap and Part D plans. And CMS has proposed a rule in November of 2023 on broker compensation, which is intended to address this issue that brokers might be steering people to Medicare Advantage plans when it's actually not in the enrollee's best interest. And just all this to say, you know, as I kind of mentioned earlier, you know, people are seeing a lot of advertisements for Medicare Advantage. We did an analysis and 85% of the ads included were for Medicare Advantage plans, and few, if any, ads mentioned the traditional Medicare program, which isn't surprising. You know, CMS isn't advertising one way or another on plans, but again, it might leave beneficiaries without a clear understanding of their coverage options and also the trade-offs of choosing one plan over another.
Thanks, Meredith. And Greg, can you talk a little bit about the new regulations for marketing of Medicare Advantage plans and anything you have to add to what Meredith described?
Sure. So we have been supportive of, or Kaiser Permanente has been supportive of reducing misleading marketing tactics and ensuring that beneficiaries are really being provided with the information and education they need to make an informed decision. And I don't think anybody wins when a Medicare beneficiary is convinced to sign up for a plan where their drug's not on the formulary, their doctor's not in the network, they have a really high out-of-pocket cap they don't understand, or their dental benefit that they think is going to be generous enough is not generous enough for what they really need. So it's in our best interest and in the industry's best interest for beneficiaries to understand the product that they're signing up for, and that they make the decision that's best for them. And that is challenging. It's a complex decision. There are a lot of different factors to weigh. Health status and needs change over time, and preferences also change over time. So you may find yourself when you age into Medicare, being more interested in having additional supplemental benefits, and in exchange for a provider network, and that preference may change later on in your life if you want a more open network, or you can't find a Medicare Advantage plan in your service area that has a particular doctor or hospital. So all those factors really do lead to agents and brokers needing to have the right financial incentives to give beneficiaries information that they need to make those decisions. And we also supported CMS's proposal to limit these extra sort of administrative fees that Medicare Advantage plans have been paying to agents and brokers outside of established commission caps in order to steer volume. And combined, I think all those reforms from the last couple of years will really improve the sort of experience that Medicare beneficiaries have for signing up for whatever coverage option best meets their needs, but also ends up with them in a happier place, so they're not disenrolling from their plan because they didn't understand what they were signing up for.
Thanks, Greg. Meredith, you mentioned that, you know, obviously brokers don't get commission for beneficiaries signing up for or staying in the original Medicare fee-for-service program, and that CMS doesn't do much to advertise it to counterbalance the Medicare Advantage marketing. Do you think CMS should do more to inform beneficiaries and market the original Medicare fee-for-service program?
Yeah, I can't say necessarily what CMS should do, but I mean, they do, you know, there is the Medicare and You handbook that they send out every year. They do send out emails and different, they do have outreach efforts, you know, to educate people about their plan options. But no, one of the things they don't generally do is advertise on television, which is where a lot of people are seeing their Medicare advertisements. But I would say in general, you know, for people being more informed about additional sort of unbiased opportunities to learn about their Medicare coverage, such as calling 1-800-Medicare or reaching out to their local SHIP, which is the State Health Insurance Assistance Program, and making sure those are well funded is important as well for, you know, encouraging consumer understanding of their Medicare options.
Thanks, Meredith. So I know you can't say they should, but I can say it. During open enrollment, CMS should probably run public service announcements to educate beneficiaries about that the original Medicare fee-for-service program exists, and where they can get more information on that. But let's change our area of focus to prior authorization. Greg, can you tell our audience a little bit about what prior authorization is? Why would plans want to use prior authorization when the original Medicare fee-for-service program has little or no prior authorization? And then what are people upset about with regard to prior auth?
Yes. So prior authorization is a utilization management tool that health insurance plans employ to first determine that a particular item or service is medically necessary for a given beneficiary. So a provider, a physician or other hospital, before they provide or deliver a particular service, may have to request that the Medicare Advantage plan review the service and the medical history or the relevant clinical details for a given beneficiary to determine that they meet the threshold or standard for providing that service. So the first part is to make sure that that is medically necessary. In traditional fee-for-service, that doesn't happen as prior auth on the front end. What it looks like more often is that the Medicare administrative contractors who are responsible for paying provider claims will deny a provider claim on the back end for not being medically necessary. So the service is still provided, the provider doesn't get paid for it in fee-for-service. So it's happening in advance in Medicare Advantage. The second function of prior authorization is to ensure that the service being provided is going to be safe from a clinical perspective, making sure that since the health insurance plan may have more information than an individual provider on the drugs that they're taking or other elements of their medical history, that the item or service that is being requested by the provider won't have any other kind of interaction or downstream negative consequences. And the third piece is to ensure that the service being provided is of high value or not low value. And when you compare Medicare Advantage and traditional Medicare in terms of sort of like low value services where there is a relatively low improvement or clinical gain for the cost of providing a service, Medicare Advantage plans have a much lower rate of covering and paying for low value services compared to Medicare Advantage. And part of the reason that tool exists also is because in a fee-for-service environment, there may not be fully aligned incentives between providers who are generating revenue by delivering the services and the health insurance plan who's covering the cost of those services. Prior authorization within value-based payment arrangements or integrated delivery systems often looks really different because those financial incentives and also the flow of clinical information and data sharing look really different.
Thanks, Greg. And then I think Kaiser Permanente may use prior auth less than some other Medicare Advantage plans. Why is that, and how does that come about?
Yeah, we do because of the nature of our integrated model and the coordination of care that our clinical partners are able to provide amongst each other and then also in exchange with the health plan. And we have an electronic medical record that the health plan and our medical groups are all on the same platform for. So we don't have to go through the process of exchanging clinical information back and forth between the providers and the health plan, but also because the work of determining medical necessity and ensuring the delivery of clinically safe and high value care to our members is done primarily with our medical group partners rather than as a function of the health plan for the most part.
Thanks, Greg. Meredith, what have you seen as far as the impact on prior authorization on providers and beneficiaries in Medicare Advantage?
Yeah. So KFF, has done some work on this, and our data show that virtually, all Medicare Advantage enrollees, or over 99%, are in plans that require prior authorization for some services. And another analysis showed that over 35 million prior authorization requests were submitted to Medicare Advantage in 2021. And as Greg said, optimally, prior authorization deters patients from getting care that's not truly medically necessary, which reduces costs, for both insurers and enrollees. It can also create, hurdles and hassles for beneficiaries and their physicians that may limit access to care. So, prior authorization can lead, to delays in getting care, and also, just adds to provider burden, particularly if, different insurers that they work with require sort of different documentation, for prior authorization requests. In addition, before some of the most recent prior authorization rules went into effect, there was evidence that in some cases, care was being denied in Medicare Advantage plans that would have been approved had the person been in traditional Medicare. And Medicare Advantage is required to cover all the same services as Part A and B. So that was something that CMS, clarified in their recent guidance, that Medicare Advantage plans have to follow traditional Medicare coverage guidelines, and local coverage determination, national coverage determinations, and local coverage determinations, and follow some certain rules if medical necessity wasn't clear. There's also been concern about use of AI and algorithms in prior authorization, and that those were sort of being used to deny care without, specific regard to individual circumstances. So that is something also that CMS has recently clarified, that plans can still use these algorithms, but it can't, supersede an evaluation of each individual's circumstance. And yeah, I'll stop there.
Thanks, Meredith. And then Meredith, you wrote an article about how gaps in Medicare Advantage data limit transparency. Can you tell our audience a little bit about what you found and why that's important?
Yeah, so one of the areas, data transparency and oversight of Medicare Advantage is important as more people are enrolled in the program, and more spending is allocated towards the program, but we don't always have a clear understanding of how the program is working for beneficiaries. One of the areas actually where we could use more data is on prior authorization. Though CMS has, issued some new rules related to prior authorization, including having insurers post public information on their website. We still don't have information about, prior authorization denials by type of service, for example. We only have, information on aggregate denials or information at the plan level. Currently, we only have information at the contract level. And what that means is that we're just, not able to assess things like whether, certain services are denied more frequently than others, or whether certain plans tend to deny services more often than others. And that is information, that could be useful to people, particularly if they have like a service that they tend to need prior authorization for, say like every 3 months, to know, whether a plan has tends to require prior authorization, might be informative when they're selecting their plan. Another area that we've talked about in terms of data gaps is the use of supplemental benefits. CMS has recently made some changes to require plans to include data about use of supplemental benefits that should be available, I believe, starting in 2025. But currently, we don't have data about how often they're used, how much people are spending out of pocket, whether, there's differences by use in certain areas. And we're also just not able to assess whether the use of these benefits truly has a positive effect on health outcomes or affordability, despite a fair amount of money being allocated to these benefits. So, again, just having more oversight of the program as it, becomes a bigger part of Medicare, is important. And CMS, recently put out a request for information on various aspects of Medicare Advantage data, which builds on one they put out in 2022. So they're, very much interested in this area as well.
Thanks, Meredith. Greg, anything to add regarding data transparency?
I would add on prior authorization too, that one other challenge with the prior authorization process is the kind of exchange of information between health plans and providers. The prior authorization requests are not always complete, or maybe missing certain kinds of data that then require the health plan to go back to the provider and ask for more information. And that process can be more manual than everybody would like. So part of the new prior authorization rules that Meredith had just mentioned would include Medicare Advantage, but also other government programs, and require the implementation of electronic prior authorization. So the process will be interoperable and electronic, and should smooth a lot of the administrative burden. So I think that sort of process improvement change, combined with the new reporting requirements that all government health plans will be required to comply with and will be reporting, will shed a lot of new light on what's going on with prior authorization, maybe at a more macro level than everybody would like, but will at least be a good start for that particular area. And then I would say on supplemental benefits, similarly, the requirements that Meredith mentioned around reporting are going to be done to start at a more aggregate level in terms of the population of beneficiaries using particular supplemental benefits or what they cost. I think there is interest in having individual beneficiary level information on use of supplemental benefits. And one of the big challenges with collecting that data has been supplemental benefits don't kind of fit the pattern of a claim for or an encounter for a medical service. So it becomes challenging to move from reporting like a visit to the dentist to something like if you got a home improvement modification, or you had a caregiver come to your house once a week for 6 weeks, and like, how do you record that? Or if you had some of these other more flexible supplemental benefits or ones to address health-related social needs, they become challenging to code and document within some of the existing data systems, like the Encounter data system.
Great, thank you. And so I know we're short on time, so let's turn to the future of Medicare Advantage and a look ahead. So Meredith, we got a question from the audience. If Medicare Advantage plans are paid from the Medicare trust funds, does that affect the financial viability of the Medicare program as a whole, and the viability of Medicare Advantage in particular?
It definitely affects the solvency of the Medicare Part A trust fund. Medicare, when Medicare is paying Medicare Advantage plans, if they are paying them more, to deliver Part A benefits, that is coming directly from the trust fund. So it does add pressure to the Part A trust fund. And so it's something to consider. I think the trust fund date, I think it's 2035 right now, but I'm not entirely sure. So there's less, immediate pressure, but this is something that, is consistently an issue when it comes to Medicare, is the solvency of the trust fund. And now that more people are enrolled in Medicare Advantage, it is something, to consider as we think about ways potentially in the future to either reduce or change Medicare spending. And then for Part B as well, Part B is financed in both by premiums and general revenues. So it's not, it doesn't draw down on the trust fund, but as Part B spending goes up, premiums go up. So, Part B premiums will just go up across the board, both for people in traditional Medicare and Medicare Advantage. And MedPAC estimated that the current payment system, resulted in $13 billion in higher Part B premiums for 2024. So that's, something to keep an eye on, for people in the program in particular, that, their Part B premiums might continue to go up over time.
Thank you. And Greg, are there any proposals in Congress or that are from CMS that you think we should be paying attention to that could mean changes for Medicare Advantage in the future?
Yeah, so I would expect there to be a more serious conversation in Congress about reform to Medicare Advantage payment under the next presidential administration. There won't be any serious conversation about that this year, given the election. But there hasn't been major changes to the program really since the Affordable Care Act was passed in 2010. And I think Congress will probably first look at a number of long-standing MedPAC recommendations to address issues around risk adjustment and coding, the star ratings system and quality bonus payment, the encounter data system, and a handful of others, and also how the benchmarks are determined. A lot of the payment system in Medicare Advantage right now sort of reflects a number of adjustments that were made to achieve the political consensus necessary to pass the legislation, and those adjustments may not be no longer be appropriate or serving the intended purpose. And so I think some of these different peculiarities will be revisited when Medicare Advantage is looked at more holistically. And I also think the Medicare fee-for-service benefit is still the 1965 like Part A and B benefit. And I don't know that there's political will to really change that, but there isn't really a health insurance product that looks like that anymore. And so sort of looking at more comprehensive Medicare reform may be something that's part of a discussion around entitlement reform, deficit reduction, or reducing the debt when that topic comes back to members of Congress.
Thanks, Greg. Meredith, are there particular proposals either in Congress or from the agency that you think we should be paying attention to?
I don't think there's anything there's on the horizon right now that will really drastically change the Medicare program. It's one of those, especially in an election year. There's not usually a lot of political appetite to really address changes to the Medicare program. Medicare is consistently popular, and people are generally satisfied with their Medicare coverage, both if they're in traditional Medicare and Medicare Advantage. So at least in the short term, I don't think there's kind of really any major changes to the program on the horizon.
Thanks, Meredith.
Jim, sorry, one other thing to mention, and my apologies. I would also recommend that folks look at the Alliance for Community Health Plans Medicare Advantage for Tomorrow platform, which is a series of recommendations for improving Medicare Advantage that are coming from the perspective of sort of regional non-for-profit integrated delivery systems, of which we're a member. So making incremental forms to the Medicare Advantage program that would improve the experience of beneficiaries and also enhance competition among plans.
Thanks, Greg. We'll make sure to include a link to that in our follow-up notes from the program for our audience. And then also, is there, Medicare Advantage seems to continue to grow and grow, with 60% by 2030. And then the payment system is based on, traditional Medicare fee-for-service that more and more becomes people that were aware of Medicare Advantage but didn't choose that. Is there a tipping point where the fee-for-service program becomes sort of an irrelevant way to set payment for Medicare Advantage?
We don't, yes, we don't know what the tipping point is. And I would say that the CMS Office of the Actuary still believes you can set reasonable and appropriate Medicare Advantage payment rates in Puerto Rico using Medicare fee-for-service experience, which represents between 5 and 10% of the population, I think. So from an actuarial perspective, the tipping point may be very far down the line in terms of looking at claims experience to set payment rates. The political tipping point in terms of how we think about the Medicare program and who's a representative beneficiary and how we want to set payments for Medicare Advantage is probably sooner than that.
Thanks, Greg. Meredith, do you have thoughts on that?
Yeah, I mean, I agree with Greg. I think, we don't know, what that tipping point is. But again, it sort of just, raises questions about, the viability of the traditional Medicare program, long term, and, kind of what the cost to the federal government and taxpayers ultimately is. Again, I don't think that'll be an immediate area of discussion, but it is something I think down the line that Congress is going to have to grapple with in terms of the cost of the program overall.
Thank you, Meredith. And that brings us to the end of our time today. But before we end, Meredith, I wanted to ask you if you had sort of one point you thought our audience should take away to say that they learned today about Medicare Advantage.
I would just kind of reiterate sort of what I just said, that it's just, the traditional Medicare is currently on track to diminish as a source of coverage. And we should continue, to think about what that means for the Medicare program and the importance of the viability of a traditional Medicare option, and also kind of the fairness in terms of being in traditional Medicare versus Medicare Advantage, having, extra benefits that are not available to people in traditional Medicare. And again, just the higher costs in the program, are we able to clearly evaluate, the benefit it's providing to people, and if the higher costs, are worth it in Medicare Advantage versus traditional Medicare.
Thanks, Meredith. And Greg, what's the one thing you'd like our audience to remember from our conversation today?
Yeah, I'd like everybody to remember and think about the Medicare Advantage program as a market and not one sort of monolithic payer, the way we talk about Medicare fee-for-service. So Medicare Advantage is really a conglomeration of Medicare Advantage plans that are all offered within particular market areas and available to certain Medicare beneficiaries and operate within sort of all these different constraints: local provider networks, benefit design, health status, beneficiary preference. And so a lot of the discussion about the Medicare program overall is a discussion about averages and about overall payment rates and about kind of behavior that's being observed within the program writ large. But all of that information is really based on individual Medicare beneficiaries signing up for particular health plans, and there's a wide range of there's a lot of variety in the way that Medicare Advantage plans can be structured and how they can deliver care. There's a lot of flexibility, and just to keep that in mind when you think about and consume more information about the program.
Thank you, Greg. That brings us to the end of this month's forum. Thank you to Meredith and KFF, and to Greg and Kaiser Permanente. Also, thank you to the Applied Policy team, and of course, you, our audience. And links to the newsletter and the Northern Virginia Health Policy Forum website are in the chat. We hope you'll sign up for our newsletter, and we'll be sure to send out some show notes after the program with the link I mentioned and ways to see some of Meredith's work and how you can sign up for our newsletter. Enjoy the rest of your day. Thank you.